Hello and welcome to another episode of our Hematology podcast series, Hema Now, with me, your host, Dr. Jonathan Sackier. This series was designed to spotlight the leading experts in all subspecialties of hematology, and today I'm delighted to be joined by Dr. Christopher Patriquin. Christopher brings a wealth of knowledge and experience in the field of hematology and rare diseases. Along with his medical degree, Christopher holds a bachelor's degree in health sciences and a master's degree in health research methodology, specialising in clinical epidemiology. His impressive academic journey includes fellowships in hematology with a focus on thrombotic microangiopathies and complement-mediated diseases. Currently, Christopher serves as an assistant professor in the Division of Medical Oncology and Hematology at the University of Toronto in Canada. He's also a consultant in hematology and apheresis medicine with the University Health Network and Sinai Health Systems in Toronto. He plays a pivotal role in clinical research into rare diseases, especially those linked to apheresis medicine and complement-mediated diseases. He's established specialised clinics with the hope of advancing care in these rare conditions. When he's not immersed in research, Christopher enjoys spending time with his partner and their dog Huxley and taking long hikes. He's also a pianist, having rediscovered his love for music during the pandemic. Outside of music, Christopher also loves hosting dinner parties, reading, exploring the world through travel with his partner, as well as through his international work in hematology. So welcome to the podcast, Dr. Christopher Patriquin. So Christopher, welcome. Nice to be chatting with you.
Hello, thanks for having me.
So before we get into the meat of it, I have to ask you a couple of questions. First of all, Huxley. Was the pup named for Julian Huxley, Andrew Huxley, Aldous Huxley, Leonard Huxley, or another Huxley? And what kind of dog is he? And also, you say you're a lover of dinner parties. What would the menu be? And you can have your dream guest. Maybe it's a Huxley.
For Huxley, it's a bit of a circuitous story. So in secondary school and my university undergraduate biology classes, I really dug into the evolutionary theory and to Darwin, and still, of course, find it fascinating. And one of the players at the time was Thomas Henry Huxley, who was given the epithet Darwin's bulldog by really how much he was expounding the new theory. And I thought at the time it would be fun to have two dogs, actually, Darwin and Huxley. And then I kind of forgot about it. And at the same time, I've always been a lover of dystopian and speculative fiction. So, of course, I've read T.H. Huxley's grandson's book, Aldous' book, Brave New World, and among other works of his. And so then years later, when my partner and I were looking to bring a dog home with us, we came across this beautiful 3-year-old Vizsla who had been returned to his breeder, and we simply fell in love with him. And when we looked at him, he just looked like a Huxley. So here we are.
That's a great story. I had a Weimaraner. I've always named my dogs for food. So I've had like bhaji, chutney, haggis. I've always had
that's
foods.
fantastic.
I love the idea of famous authors. I know someone who named all his dogs for characters from Lord of the Rings. So there was Bilbo and Frodo and all the rest of it, Gandalf. So dinner party. What would the menu be? Who would your guest be?
Yeah, so at the risk of becoming serious too early on in the podcast, if I had an opportunity really to bring anyone to a dinner party, I would choose my mother, actually, who passed away about 10 years ago, just as I was heading into my hematology Royal College exams. And so she really never got to see how my career would progress. And even though she was such a driving and supportive force all throughout my life, of course, and I think we would have lots to talk about, not to mention that she never got to meet Huxley, so I think that would be really special. And I think so Mom was born in Germany, so I think I would try to do a traditional German meal for her, the gamut of Spätzle and all the meats and pickled cabbage and maybe some Alsatian Riesling or something like that, and would try my best to recreate the German apple cake that she always used to make for me when I was a kid, but I don't know if I would do it to her standards. But I suspect suspect it would be a long dinner party. I might not let her go.
Yeah, I love playing that game of, if you can have the ideal dinner party, who are the guests that you would invite? I think you learn a lot about people. So, having
Yeah.
learned a little bit about you, let's dig into your professional work. Not that your cooking is, I'm sure, not professional, but your research focuses heavily on rare diseases like what used to be called idiopathic thrombocytopenic purpura back in my day, and it's now thrombotic thrombocytopenic purpura, and complement-related conditions, mediated conditions. Can you explain the unique challenges of diagnosing and treating these rare conditions, and how registries like the International Paroxysmal Nocturnal Hemoglobinuria, thankfully you abbreviated to PNH, to the registry, how they help address those challenges?
Of course. So with any rare disease, you're already starting behind a little bit. You're at a disadvantage or a handicap because before anyone can diagnose you, they have to think about that diagnosis and test for it, if indeed there is a test that's readily available. So for many diseases, they can present also with rather non-specific symptoms or manifestations that can be also seen in much more common conditions. So a lot of patients will have a very lengthy time between those early disease symptoms and actually getting a diagnosis. As an example, we recently reviewed a cohort of patients followed in Toronto, and the median time to reach a diagnosis from the initial recognized symptom was nearly 5 years, though the range was quite broad. And the median number of physicians was also quite high. About four physicians saw the patient before a diagnosis was made, and those data, those experiences aren't dissimilar from what's been reported elsewhere in the literature. Um, and then once a diagnosis is made, it really depends on if indeed there is a targeted therapy available. And most rare diseases don't yet have that luxury. So for immune TTP, the cornerstone of treatment remains therapeutic plasma exchange and immune suppression. And more recently, caplacizumab was added to the list of first-line therapies, but unfortunately in Canada did not pass health technology assessment body review. So we no longer have access to that, though we haven't fully given up hope. But thankfully, many other countries do have access to it, and we're seeing already the improved outcomes. So, that's another example of just some of those challenges, whereas even if a therapy is available, it may not get through to the commercial availability, even if it's past the clinical trial and regulatory gauntlets. Um, and then sorry, go ahead.
I was just going to say, in the registry.
Yeah, so the International PNH Registry, or that's run by the International PNH Interest Group, or IPIG, just to shorten the term, is going to be a really valuable research endeavor because it will allow for one central location to recruit patients with PNH regardless of the therapy they're on. And in fact, they don't need to be on therapy. So we can centralize it to a global center, and that just would increase the power of the analyses and conclusions that we can make with those data. And of course, it's just one example of many rare disease registries out there that have been able to provide important insights into natural history and disease complications and treatment outcomes.
Right, right. Fascinating. I had a series of patients that I saw with TTP who needed a splenectomy,
Mm-hmm.
and I did a bunch of laparoscopic splenectomies, and it was lovely to be able to, these poor people who are dealing with enough of a burden. At least we could do the operation in a minimally invasive fashion.
Of
We also
course.
did one on a patient with, in fact, the only patient I've ever seen with this condition, Hunter-Hurler syndrome,
Oh,
um,
wow.
gargoylism. And he was
Mm-hmm.
a young man, early 20s, and he had massive splenomegaly. And for a magic trick, we did a laparoscopic splenectomy. This thing went from his diaphragm into his pelvis, but we managed to get it into a bag, fragment it, withdraw it without, disseminating chunks of spleen and inducing splenosis. But
Mm-hmm.
fascinating conditions. So you did a recent paper, you wrote a recent paper on cognitive decline in TTP survivors and explored the role of white matter damage in these patients. What led you to that research focus? And what were the key findings that clinicians listening in should keep in mind?
For sure. So for years, we've known that the TTP patients, even once they've cleared that acute inpatient stay, they no longer need plasma exchange or high dose steroids or rituximab or splenectomy, even that they may develop chronic headaches, difficulty focusing, neurocognitive changes, depression, anxiety. And what has been missing is a clear explanation for why this may happen. So our group, which is headed by Dr. Susan Wong in London, Ontario, she's a nephrologist and also a TTP expert, decided to investigate using sensitive imaging techniques and looking at blood-brain barrier permeability in these patients once they've achieved clinical remission. And then we look another 6 months later. So we initially published just a pilot study of 7 patients that showed really significant increased blood-brain barrier permeability, which is pathologic or pathophysiologic in these patients. And we think that there is probably a link related to some of these neurocognitive and mental health issues that we see. And more recently, actually published a paper of 20 patients with MRI imaging and correlated that with some findings of reduced neurocognitive and mood in these patients. How this will translate into a therapeutic strategy remains to be seen. There was a fascinating paper a few years ago, a mouse model of TTP, and quite interestingly, they found that some experiments when conducted in the mice with von Willebrand factor knocked out, didn't have the same degree of blood-brain barrier damage. So, as an analogous clinical approach, we do wonder if the use of caplacizumab, which again we don't have yet access to, but hopefully will, it inhibits platelet VWF interactions. So maybe it would provide some protective effect in that way. And so there's more to come there. We're trying to analyze those patients who did and did not have caplacizumab as part of their treatment to see if there are some differences there.
Okay, so that's fascinating. Going back to the blood-brain barrier, what's the mechanism by which, what does it become more leaky?
It does,
Less
yeah.
leaky, more
And
leaky.
so we do wonder if it's related to the microangiopathic damage, but certainly it is much leakier even out to 6 months. There is some resolution that we see at that time point, but it doesn't go back to normal and can look even worse than even an acute stroke. So there is some suggestion there that chronicity of this increased permeability could contribute to these issues over time. But again, very early days and a lot of work to be done still.
Fascinating, absolutely fascinating. So, uh, you contributed to several clinical trials, of course, and including studies which explore. I have to tell you, I can never pronounce these bloody drugs. Pegcetacoplan. I can't pronounce the damn thing. I'm a reasonably intelligent chap, but I really struggle. Someone actually told me that they deliberately make them difficult to pronounce.
I think so. Yes, I think it's an
Um,
exercise.
yeah, so it was the first targeted complement-3 PNH therapy. Can you share how this new therapeutic is changing the landscape for patients living with PNH?
Absolutely.
And
So
please
the
pronounce the
no,
drug.
please.
Educate me.
So it's called pegcetacoplan, but there was even a YouTube movement at one point to show people how to say it. So you're not the only one, and
I
we,
looked it, I looked it up, and I do lots of these podcasts, and forever there's these, them everything ending with mab, right? They
yes.
are all completely unpronounced. I'm just a simple surgeon, I speak grunt.
I find that these at least are a bit easier to pronounce than the full names of those CAR T cell constructs, but
Yeah,
I definitely get your point.
yeah.
So in terms of the PNH therapy and how this is advanced for background, the most common standard of care treatment for patients with PNH has been terminal complement inhibition, which targets the complement component C5, so essentially the start of the membrane attack complex. And this was initially done with eculizumab, and more recently the longer acting version of that, which is ravulizumab. And for many, the strategy is still first line, and we have over 2 decades now of experience with C5 blockade. As you mentioned, pegcetacoplan is the first proximal complement inhibitor to be approved for management of PNH, and it's a twice-weekly subcutaneous infusion, so a different route as well, and it directly inhibits C3, which is the proximal complement molecule that's central to the three canonical activation pathways. And it's also the molecule that can contribute opsonins for targeting of removal via the reticuloendothelial system. So when we have a patient on a C5 inhibitor, some patients develop essentially iatrogenic extravascular hemolysis that can cause persistent anemia and even transfusion dependence in some. And it's because the red cells that previously would have hemolyzed intravascularly now can circulate, but they continue to accumulate more C3d on their surface. So then they're marked for destruction by primarily the liver, but also the spleen. So by blocking more proximally at C3 or even earlier, as some of the newer therapies can do, this can abrogate that effect. And you see in the clinical environment significant improvements in hemoglobin.
Okay, interesting. So I mentioned in my introduction about your work in apheresis medicine. Can you explain why apheresis is playing such an important role in certain hematologic conditions?
Absolutely, it's where I spend most of my clinical time, and so broadly, apheresis is it's a category of a medical procedure in which a blood component, a plasma or cellular, can be removed and possibly replaced depending on what you're looking to do and what you're hoping to treat. The most common therapeutic apheresis modality is plasma exchange, and that's where a patient's plasma is removed whilst we simultaneously replace it with usually albumin, but plasma when there is also perhaps a component missing in the patient's plasma. So it's very highly effective in treating really antibody-mediated diseases, particularly in acute situations where there may not be enough time to wait for immune suppression to just reduce immunoglobulin production, where physical removal is needed. And this is particularly the case where those plasma components have a longer half-life, like IgG-based autoantibodies. The prototypic hematologic disease for this really is acquired TTP, and in that situation, we replace the removed patient plasma with donor plasma because the procedure serves both to remove anti-ADAMTS13 antibodies that are causing the disease and also replace the deficient protease, the ADAMTS13 itself. But this is really just one of the many indications for plasma exchange in hematology and beyond. And of course, we can use it hematologically for other things like red cell exchange for patients with sickle cell disease. And that allows us to rapidly reduce their percentage hemoglobin S to reduce sickling and its many complications. But it's a very broad and fascinating field, and really is important to have multidisciplinary collaborations here, because you can't be an expert in every disease that you might treat with that machine. We try our best to learn as much as we can for what we're treating, but if it's a neurologic condition, if it's an endocrine disorder, then we certainly have to collaborate broadly.
So for TTP, what would the regime be? How often would you have to do apheresis for TTP?
So for TTP, really with even just the suspicion of TTP, we would start daily plasma exchange. And often, though it can vary, we'll do 1.5 times the patient's plasma volume replaced with plasma, as mentioned. And we really would do it daily until we see normalization of their platelet count. And really what our usual goal is to see a platelet count over 150 for a couple of days, after which we can pause and monitor. The therapies that come with that include at least corticosteroids. In some jurisdictions, upfront rituximab is also used to really start to address the antibody production as well at the same time. Sometimes we can't do that in Canada. Most of the time we have to wait for either a relapse or refractory disease to get access to rituximab, but that's another battle that we're fighting.
And if you've achieved normalization of the platelet count, how long can a patient go before they have to come back and go through the palaver again?
So hopefully they will reach clinical remission. So after they have normalized their platelet count, we monitor them very closely, and they're still on corticosteroids, which we would taper gradually. They may require, as mentioned, other immune suppression. But once they've reached that platelet normalization step, the most patients won't require longer term therapy, although they can have exacerbations, in which case we would need to resume plasma exchange again. And usually in that situation, we may be a bit more gradual in our removal, with a bit of a tapering schedule, say 3 times a week, then 2 times a week, then once. But usually upfront, we'll get them to that normalization,
Mhm.
and then hold.
Fascinating. Could you just give us like a rundown, a list of some of the other diseases? You mentioned IgG, you mentioned TTP, and you mentioned neurological disease. Give us a few others that, some of our listeners, well, starting with me, may not know about.
Sure, absolutely. So, from a plasma exchange perspective, the most evidence is there for things like myasthenic crisis, for generalized myasthenia, the anti-GBM disease, previously known as good pastures. There's been less use of it in the context of ANCA associated vasculitides over the past years, although that is in flux a little bit based on some newer evidence. Across other indications, there's hyperviscosity in the context of paraproteinemias or Waldenström's. So it really runs the gamut. So each cycle of what's called the special issue of the Journal of Clinical Apheresis, which is released typically every 3 years by the American Society for Apheresis. Those diseases and indications are expanding, and what we try to do is give it a category. So category 1 indication is where you would use plasma exchange or some apheresis modality upfront. Category 2 is where it would be a second line therapy, often in conjunction with something else. Category 3, which is often where we spend our time, is really where it's more case by case, where there may be some benefit, but there isn't the same level of evidence to support that, or the use may be a bit more equivocal.
Okay. I've certainly got my reading cut out for me now. I've got a long airplane ride coming up. I think I'm going to read up about this stuff and learn more
Okay,
about it. You
I could.
mentioned good pastures and said previously known as, or was known as. So why is it not known as? And you also mentioned Waldenstrom's, and I believe he's been cancelled. Is that correct?
That seems to be the movement essentially, and not even just in the context of canceling if there's a concern of previous behaviors of the person who has the eponymous disease name, but at least within the guidelines, and I think more broadly, we're seeing nomenclature come from the pathophysiology, more so anti-GBM disease, as an example, and then just mentioning the lymphoplasmacytic lymphoma instead of Waldenström's. But that is, I think, variable a little bit, but I think there's in general that movement towards trying to have more effective names to make it easier to know exactly what you're dealing with.
Yeah. I think this could be a whole other podcast,
It
Christopher,
could. It
about
very much could.
the sensitivity of all this. I think that, um, I think we're in danger of losing some of our heritage whilst
Mm,
recognizing some people might have done some bad stuff.
right.
Um, yeah, well, separate podcast, I guess. So the International PNH Registry is undergoing a significant transition. How will moving away from having industry-funded oversight impact research, for example, by enabling enrollment of patients who'd otherwise be excluded?
So the IPEG registry is the new venture, and even though it will still have industry sponsorship, it's at further arm's length. So because it's run by the International PNH Interest Group with financial support from industry partners, it's different from the previous registry, which was essentially owned and operated by Alexion, because at the time, for many years, they were the only company with an approved therapy in the space of PNH. But with the availability now of pegcetacoplan, as we've talked about, there's iptacopan, which is a factor B inhibitor, crovalimab, and some new other C5 inhibitors also coming. These are all made by other industry partners. So we needed a registry that would permit really entry of any patient with PNH on any or indeed no therapy, instead of multiplying the work and having a registry for each specific drug. So it's essentially designed such that a sponsoring company have a silo of patient level data that they can use for regulatory submissions and safety reports. However, there are core data points that are collected from any patient in the registry, irrespective of the therapy they're on, which will allow us to observe their outcomes across the various silos and even in the core registry if patients are specifically not on a therapy. And we're fortunate too that the invaluable data from the prior registry won't be lost or ignored. So for any patient who was enrolled in the previous registry who transitions over, they can consent to have their data brought over with them. And I think it'll be a very important tool, not just to monitor the effect of these therapies, but with registries, we can focus also on inclusion of vulnerable populations like pediatric patients and pregnancy, which of course are usually typically underrepresented or specifically excluded from clinical trials.
Right. That's interesting. I mean, I know there are sensitivities about this in many areas of medicine, but there's the cold, hard light of day as stuff needs money to make it
Yes.
happen. And I've been fairly outspoken about so-called perceived conflicts of interest. I think it's about conflicts of disclosure.
Mm-hmm.
I think if one discloses what's going on, after my many years in medicine, it's my belief that our colleagues are overwhelmingly good people. And it's been my experience that people in the pharmaceutical industry are overwhelmingly good people. And there's not some kind of cabal of evil minded people endeavoring to manipulate us to prescribe medications, for instance, that patients don't need. So I would like to see us push back a little bit
Mm,
against the naysayers, frankly, because who ends up suffering is the patients. If we don't have the money to do the things we need to do, the patients suffer.
absolutely.
And in fact, I'm going to come on to that. That's inspired a thought. But first of all, let me ask you, what developments are at or just over the horizon in your specialty that have you rubbing your hands with glee?
I think for the treatment of PNH and most likely other complement-mediated disorders like atypical hemolytic uremic syndrome, even C3 glomerulopathy, there are these novel approaches, including targeting of the lectin pathway, which has not received the same amount of attention as C5 inhibition and the alternative pathway, but there's dual target therapies that are being developed, possibility of expanding siRNA technology to reduce expression of complement components. So I think this is great because it continues to show that there's interest and investment in the field. And if these are found to be safe and effective, it means additional therapeutic options for patients. And at the same time, it will further advance our understanding of the complement system in human health and disease. And related to that, we're in early days, I would say, of having useful validated biomarkers for use in the field, and it could really benefit from that. It really across the patient journey, confirming diagnosis, potentially identifying upfront the best therapeutic choice for some to be a bit more specific in terms of our prescribing, assessing treatment response, disease control, all of that, and even monitoring for disease recurrence subclinically before a true relapse happens. So I think there's a lot of early work going on, and I'm quite excited to see how that will benefit our patients in the years to come.
Oh, fantastic. So I was formulating this as you were speaking because your specialty in my professional lifetime has changed dramatically. The ability to diagnose, I mean, we've mentioned diseases changing their name, going from idiopathic to thrombotic, right? So you know what's
Mhm.
going on. So, how do we, given the challenges of ever more complex and expensive therapies, these things cost money to develop and they have to recover that investment. We've got an expanding population base and a widening wealth gulf. And in Canada, where you've got a similar system to the United Kingdom in the centralized healthcare delivery, and even in south of the border for you in the United States, access to care becomes an issue. So how do we ensure equity and equality of access to care and make sure that, we can treat these patients, that you now have the tools to treat them with? You've already mentioned that you can't access certain treatments in Canada.
Hmm. That's such an important question, and I'm afraid I don't have the full answer, other than that we need to continue to advocate for this specifically as physicians, and certainly in partnerships with patients, patient advocacy groups, which are exceptionally strong and deserve listening to, and rare disease societies as well. I think there are some national rare disease strategies out there that have made some early strides, but and even close to home, the Canadian federal government recently committed a significant sum dedicated to building the strategy, but we're very early on in what that's going to look like. But I think what we know is that using those funds just to pay for drugs is not the right thing. We need to invest in sustainability and accessibility, as you mentioned, and reduce that postcode lottery that can be seen within a country, certainly across countries and continents. And it's still the minority of countries that have access to many of these therapies, like complement inhibition for PNH, and that is a major focus for the International PNH Interest Group to try and expand that with clinical trials and other therapies, even things like biosimilars. But of course, those take some time to be developed as patent laws change and all of that. So I think there's still certainly a lot of work to do, and we have to just really continue to push for responsible pricing and equitable distribution as much as we can.
Yeah, and that requires leadership.
Yes.
And sometimes asking for forgiveness instead of permission to get stuff done. I sense that you probably fall into that group, Christopher. There's a question I love to ask guests. If you came across a magical genie who could grant you 3 wishes for your area of healthcare, what might those wishes be?
I was never good at answering these types of questions. Even as a kid, I always struggled to be creative and interesting. But I think I would say, in the shortest term, I would ask the genie to figure out a way to shorten the time to diagnosis for patients, to have some magical way, or hopefully even a real way of making those diagnoses more quickly, with novel algorithms or assays, or even work using AI to support that decision-making process, because it's crucial that we make those diagnoses early. And I really still worry that there are patients out there who don't even make it to us and succumb to a disease without it even being named for them. My second wish, I think, as well as we've already discussed, we need global availability of these therapies at affordable prices, and maybe the genie could make them entirely free. Who knows? But and that, I think, really includes therapies that are yet to be created for diseases still lacking effective options. And ultimately, I think for a third wish, I won't ask for more wishes. I would hope that eventually we could find a safe and effective cure. And I think with the growing number of immune effector cell and gene therapeutic strategies, let alone what will be developed in the future by people far smarter than I don't think this is entirely out of the realm of possibility. So with all of that said, I don't think we'll need a genie for those 3 wishes, but it may expedite things if I can find that lamp.
Well, one thing to throw out at you that, I've been involved in pushing for this in my area, is to rethink the regulatory environment. Because for a pharmaceutical or a biotech company to bring a product to market, the amount of money
Mm-hmm.
one has to spend on the process of clinical trials, and the amount of time that can take years, and those years erode the patent life and erode the potential to retrieve your investment. If we had a system whereby, having done some safety work, you've got people who've got serious illnesses, provide proper informed consent to participate in a registry type trial, to bring these things to market so that some revenue could flow to the company, and that would reduce the overall price of the treatment dramatically.
Mm-hmm.
And you can do clever statistics nowadays because as big as, you can do a massive phase 3 clinical trial, and yet when you release it to the general population, things pop up. Fen always comes to mind, right? The valve disease and the pulmonary vascular issues that didn't show up in the clinical trials. So I think we've got to rethink the regulatory environment, and it'll take people like you in your specialty to push for that. So I'm going to ask for you to be the genie on, on this one. I'm afraid that's all we've got time for today. I'd like to thank Dr. Christopher Patriquin for being with us today on another episode of Hema Now. Christopher, it was a real pleasure chatting with you.
Thank you very much. It was a pleasure.
So, folks, thanks for listening to this episode of Hema Now. If you've enjoyed listening, and I guess if you're watching this part, you definitely have, please subscribe on Spotify or Apple Podcasts or wherever you get your podcasts so that you never miss an episode. And check out our archives. There's going to be lots of great episodes in there. And please tell your colleagues, tell your friends, like us on social media. You know the drill. So until next time, please stay safe, stay well, stay curious. Bye for now.